Yes, we are live now.
Good evening, everyone. Good evening, delegates. Good evening, speakers, and good evening, panelists. I welcome you all for today's session, SAFOM's International Academic Exchange webinar, and topic Menopause Management of G.S.M. And today, our coordinators and MOCs are Dr. Ambuja Charonar from India, Dr. Apurva Pallam Reddy, India, Dr. Prema Kishan, India, Dr. Niharika Malhotra, India, and Dr. Ambuja Charonar, MD, DGO, Hyderabad. She is a retired professor and HOD, OBG Gynec Department, Osmania Medical College, Hyderabad. And she is a visiting professor, Savita University, Chennai, President, Indian Menopause Society 2021, and Vice President, Family Planning Association of India, and Faculty Resource Person, National Board, Treasurer, Society of Obstetrics and Medicine, India, Peer Reviewer, uh, JOGY JMH JK Journal. I welcome you, ma'am.
Thank you.
And Dr. Apurva Pallam Reddy, she is MS OBG, DNB OPG. She has completed her fellowship in reproductive medicine, infertility training from Brussels, Belgium, diploma in gynec endoscopy, Kiel, Germany, diploma in USG, Chennai, editor decision making in infertility, director International Fertility Academy, and editor decision making in infertility. And she's a consultant reproductive medicine and cosmetic gynecology in Phoenix Specialty Clinic, Bangalore. I welcome you, ma'am. And Dr. Prerna Kishan, FICOG and FICMCH and FIAOG. She's a consultant OBG gynec and infertility specialist and also endoscopic surgeon. Masters in Cosmetic Gynecology, Horizon Maternity and Fertility Clinic, Assam. I welcome you, ma'am. Dr. Niharika Malhotra, MBBS MD. She's a gold medalist, DRM Germany, DMIS, and FMAC and ICOG Fellowship in Reproductive Medicine, DGC. And she's a consultant in Rainbow IVF, chairperson in Foxy Young Talent Promotion Committee 2020 to 2022, and joint secretary Foxy 2018. I welcome you for today's session, ma'am.
Thank you, Monica. Thank you.
And I hand over the session.
Thank you, Monica. Wishing you all a very good evening. And it gives me immense pleasure to welcome you all for this wonderful scientific session today by the SAFOM's International Academic Exchange webinar, and the topic menopause management of GSM. As we know, menopause is that troublesome time of a woman's life when things are not at par with her expectations. So here we have a series, an array of string of wonderful speakers with us who will be dedicating the entire 2.5 hours session for the betterment of the women of the entire globe. We have dignitaries around the globe from India, Bangladesh, Sri Lanka, and many more. So we welcome you all for this wonderful session. And with this, I invite Dr. Rohan Hatatwa sir from Sri Lanka. He is the chairman, Nine Wells Care Mother and Baby Hospital, Secretary General Asia Oceania Federation of ONG, FIGO past chairman, Menstrual Disorders Committee, President South Asian Federation of ONG, and Vice President South Asian Federation of Menopausal Societies. And he has been the past president of Sri Lanka College of Obstetrics and Gynecologists. We are so much honored, sir, to have you amongst us today. And we would all like to hear your words of wisdom. The dais is all yours, sir.
Thank you. Thank you, Prerna, for that kind invitation. Good evening to everybody. And I think Professor Marianne is there. Is I think good afternoon to you, Marianne. And so my duty is to welcome everybody. First of all, I must congratulate our Dr. Narendra Malhotra, who is the SAFOC Director, International Affairs. And he is the live wire behind this program. He has been having programs with SAFOG and all the many other federations, international organizations. And this is the last one of it, and it is with SAFOMS, the South Asian Federation of Menopause Societies. So you can see the real talent and how Dr. Narendra Malhotra can organize these webinars in no time, and also getting around the really galaxy of leaders and speakers from around the globe also into his webinars. So they are very, very informative and lively programs. So I thank you, Narendra, for organizing this. And now it is, I am very happy that I am able to represent both SAFOG and SAFOMS today. And so it's a very unique opportunity given to me. Thank you. From on behalf of both organizations, I welcome everybody to this webinar today. So I am very happy to see Professor Mary and Lumsden, the CEO of FIGO. I mean, she has been with us in all of South Asian Federation programs, not only the ONG, but Menopause, not only for so many years. So I don't think we can ever have a program without Professor Marian's presence. So it becomes something missing if she is not here. So thank you very much, Professor Marian, for joining with us, and we are looking forward to hear from you. And then, of course, we warmly welcome Dr. Jaydeep Malhotra, who is the past president of the SAFOMS. I mean, she has been doing so much of work, and also in the SAFOG, she is the editor in chief. So in both organizations, she is playing a very key and active role, and I think she is producing our newsletters in time, so keeping all of us very busy. So I welcome Dr. Jaydeep Malhotra. And then, of course, we have our chairpersons, Dr. Ashma Rana, who is the past president of SAFOG, Dr. Samina Chowdhury from OGS, and Dr. Maninda Ahuja from SAFOMS. She is also a very active member from SAFOMS, who is very interested in these research projects and keep everyone in their toes. So we are happy that they are with us. And then with the lectures, we have Dr. Hemantha Perra, who will be here. Hemantha Perra is the journal editor, the SAFOMS, I mean. So he is the editor, and he's, I mean, with so many difficulties, he is trying to get everything sorted out. And then Dr. Preeti Jindal from India. And then, of course, we have so many panelists representing all the SAFOG countries. So we have Dr. Lubna Hassan, Dr. Rubina Hussain, who is a past president of SAFOMS, Dr. Sonia Malik, Dr. Litya, Dr. Ganesh Dangal, Purja Doji from Bhutan, and so many others. So I welcome all of you for this. And so we also have Dr. Ambuja, who is the past president of the Indian Society of Menopause Society. So we are very glad that so many experts and leaders in this field of menopause are here with us today. And finally, there will be Dr. Yusuf Latif, who is the Secretary General, who will join later in the program. So thank you. I don't want to take more of your time, because what is more essential is to listen to all the experts and learn from them. So I give back to the moderators to continue with the program and wish the program all the success. Thank you.
Thank you so much, sir. That was really motivating. And with this, we welcome one such person to this webinar, Dr. Jaydeep Malhotra ma'am, who has been a mentor, a guide, a motherly figure, and as someone who is a steering force for all aspirants, all young minds of India. Ma'am, we are so very honored to have you amongst us, ma'am. Ma'am is the Managing Director of ART Rainbow IVF. She has been the Vice President in SAG and Chair FIGO Committee of Reproductive Endocrinology and Infertility. She is the immediate past President of South Asian Federation of Menopausal Societies and ISPAT, the Regional Director, South Asia, Ian Daniel School of Ultrasound, Professor Dubrovnik, International University, Croatia, past member of FIGO Working Group on RDEH, member of Accountability Group of PMNCH, Editor-in-Chief of CEFOG and CEFORM's journals and many books, President Rotary Club Agra Grace, past President Foxy, ISAR, Aspire, IMS, past Secretary and Vice Chairman ICOG. The list is never ending. Ma'am, this is never going to be, we can never accommodate in one particular slide. This is impossible. Ma'am, we are so honored to have you amongst us. The dais is all yours, ma'am.
Thank you, Prerna. Thank you so much. And a very good evening to all of you. It's such a pleasure that, we have collaborative programs, and I have to congratulate Dr. Naren Malhotra for this endeavor, because we've done amazing programs with CEFOG, RCOG, with, CEFORMs, and many more, and Donald course. We've done some very beautiful academic sessions. And Rohana, thank you so much for this opportunity. It's really been phenomenal. And today, my job was to basically outline the program for all of you, which has already been very nicely done by Dr. Rohana. And I'm not going to waste any more time. I would definitely like now to invite our chief guest, my very dear friend, an absolutely amazing personality, Dr. Marian Lumsden. I'm sure all of you know her very well. She presently is the CEO of FIGO, but more than that, I have known her as a great friend from the Menopause Society. She has been the president of the International Menopause Society, the British Menopause Society, and is a very active member of the Royal College of Obstetricians and Gynecologists, and has done some amazing work as far as menopause is concerned. And her in-depth, passion, which I would say that at whatever young age she is ready to travel distances for the cause what she really believes in. And that has been an amazing inspiration for all of us. So Marian, we are really looking forward to hearing from you. I know that you have been awarded the Officer of the Order of the British Empire, an honor which was awarded or conferred on you in 2017. And that makes us really extremely proud. Looking forward to hearing you.
Well, thank you very much indeed. And it's an absolute joy to be here. Yep, and I found my slides now. Let me just get them going.
Can we invite the chairpersons for this session?
Oh, I'm so sorry. But can I leave
just 2 seconds. Just 2 seconds. Prerna, can you invite Dr. Maninder, Dr. Samina, and Ashma to chair this session?
Tahiti, can we have the slides, please? Yes. I request Dr. Ambuja Choranar, ma'am, to kindly do the honors, ma'am. Dr. Ambuja, ma'am. You are muted, ma'am. Ambuja, ma'am, you are muted.
I'm not
Yes,
heard.
we can hear you
Good
now.
evening,
Yes.
everybody. And overwhelmed with joy to meet so many friends of mine. A special thanks to Dr. Narendra Malhotra for making me part of this program. Without wasting much time, I would like to introduce all the chairpersons of today's session. The first chairperson, I invite Professor Dr. Asma Rana from Kathmandu, Nepal. She is President, Perinatal Society, Nepal from 21-23. She had innumerable awards on her credit. And I request Professor Samina Chowdhury, Chairperson, Chairman OBGYN Hospital, IRCH. She is President, Endometriosis Adenomyosis Society of Bangladesh, past President, OBGYN Society, Bangladesh, and she is Chairperson, Endometriosis Subcommittee of SAFAG. She is EC member of SEFORMS, and she's an active ambassador to FIGO. She has got so many publications to her credit, and she authored 5 books and awarded as the Outstanding Women's Award. Madam, you are welcome. Now I welcome our own Dr. Maninder Ahuja. She is President, Society of Meaningful Life Management, and very active person. She has got a dedicated to herself for the women and adolescents to menopause since 40 years. She is Vice President Foxy 2013 and 14. She is President, past President, Indian Menopause Society, and affiliations with many professional bodies are present. Her list goes on if I start reading about her contributions to Indian Menopause Society and Foxy. And this is what is Maninder. She is icon of Indian Menopause Society. You are welcome, Maninder. I request
Dr. Maninder, you can start the session, Dr. Maninder.
Yeah, I think now we should have said hello to each and every one of you, and it's a pleasure meeting all of you together after so many years on at least webinar, and perhaps soon we'll be meeting physically. And Dr. Mary, now I invite you for your lecture on the midlife health, which has been your passion for so many years, rather our passion together. And we have done so many webinars and the conferences and the panel discussions together. And it's a pleasure to listen to you, because the work you have done in midlife is really making the guidelines for the British Menopause Society. Was a great work which you have done. So over to you, Dr. Mary Lamston. We are eager to listen to you.
Well, this is a real pleasure and a great honor to be here among friends old and new. And I thank particularly Doctors Narendra and Jaideep Malhotra and Rahana Hathatur and all the other people who are involved in these extremely successful and really exemplary organizations. Now, what I'm going to do, I hope, is talk to you about health and well-being in midlife. And I'm going to cover quite a lot of ground, but what I want to do is really give examples of how you can implement things to make a difference. And as I think you're all aware, the issue is that we're all living longer. In the UK, we live to over 80. In India, it's getting on towards 80. And there will be 1 billion women aged over 50 in 2050, which is astounding. Now, there are various interesting features about all this, and I know this is true for other South Asian countries, but I found this rather good example in India, where the life expectancy varies by about 10 years between the most affluent and the least. If you look down at the bottom left-hand corner, you see the sort of Kerala region, and then in other areas, it is a lot less, such as Uttar Pradesh. And I think it would be really interesting to think more about all the reasons for that. Now, you will all be aware that in the West, the age of menopause is about 50. I know in Asia it's a bit less, but it means that women will spend probably a third to a half of their life post-menopausal. And this is a really sobering thought. And it does need a lot of thought, a lot of sort of concentration and focus, which it doesn't get. Now, the causes of death, and these are particularly India, but are reflected worldwide: heart disease, cancer, stroke, diabetes. These are really common causes of death, many of which we can actually do something to affect. And that is what I'm going to talk a little bit about, but in very simple terms. Stroke again shows this incredible geographic variation, which I didn't know about until I was sort of researching the talk in the last few days. And the incidence of stroke does vary considerably. But the bottom line is that 60% of stroke patients worldwide come from India. And that, I think, is a terrifying thought. Stroke is such an awful thing. And there are some simple measures that one can undertake to try and lessen the risk of stroke. And the first of these is to focus on blood pressure. Now, if you lower the blood pressure, even by a small amount, you will decrease stroke by about 40% and coronary artery disease by about 25%, but focusing on the stroke. So by simply focusing on blood pressure, you can make a huge difference to women's lives, because even mild strokes have massive implications for them. What other changes do you get at menopause? Well, you get changes in your lipids, cholesterol, LDL, ApoB, all these lipids, which are really pretty bad news. And so again, another facet of the menopause, of the metabolic syndrome, which I wasn't really going to focus on in this presentation, but it's something you can do something about. So again, in the women you see in midlife, give it some thought and some attention, not just focusing on their menopausal symptoms. Obesity, the same. We're looking at a rise worldwide in the level of obesity. And you will be aware, a lot of you have heard me speak before, will have seen this slide before, but it shows with 0 being the age of the menopause, premenopause, postmenopause, that visceral adipose tissue goes up at the time of the menopause. Visceral adipose tissue is very bad news in that it's metabolically active, produces all sorts of inflammatory mediators and cytokines, and is bad for you. And so it is something that one must look for, focus on. And I'm looking, who I can see very clearly, of Meninda, who I think was one of the first people in India to actually get us all dancing. And I've never forgotten that, because these are the sort of things that will make a difference. And we've been quite interested in Scotland in adiposity measurements and have done a reasonable amount of work, but I think this is one of the more important slides that is relevant to you. This is cardiovascular events and BMI. You all know that they go up, of course, but what isn't so well known is how important waist circumference is, a reflection of the visceral adiposity, and so easy to measure. All you need in your clinic is a tape measure, and you can look at the waist circumference, and then if it is over 84, but particularly 88 in Western communities, you really lay it on the line with the woman in question that they need to do something about it. You can measure hip circumference as well if you want to, but the waist circumference is critical. And so there are many guidance documents on cardiovascular health. And this one was produced by all sorts of physicians, gynecologists, endocrinologists in Europe. But it's true also elsewhere in the world that you get these features, central adiposity, insulin resistance, pro-atherogenic lipid profile. So when you can, and I know you can't always, assess lipid levels, but you can certainly assess blood pressure. And so simple measures can make a difference, because then you can do something about it. And do think about women who had preeclampsia or pregnancy-related hypertension, because they will be particularly at risk. I like throwing this in for good measure. Of course, diet is important. And one of our committees in FIGO has developed this FIGO nutrition checklist, particularly Dr. Fionnuala McAuliffe, who is passionately committed to this checklist. It's been trialed in India in particular, very useful, very simple. gets people to focus on what they're eating and how much they're eating, which is often the problem, just to see if there are ways they could improve their nutrition without too much distress. We all know what a nightmare it is, dieting and trying to lose weight. So these sort of aids, and there are others, but this one I'm extremely fond of, can be helpful. This starts in pregnancy, but we're hoping to look at post-pregnancy studies. And this is just a very simple little illustration of the sort of things you can do. I don't suggest you all leap on your bicycles and cycle round, but there are lots of ways of taking exercise, as I just mentioned, which are fun. And so these can be encouraged in women of all ages. I'll mention a tiny bit about HRT, but I think in the greater scheme of things, it's lifestyle changes which always have to come first. Now, menopause again is important. We know that in India, the age of the menopause is a bit earlier than in Europe. It will be 45 to 47 again, depending on where you live. And it's an important factor that early age of menopause has an impact on heart disease risk. And so this is something which has been shown again and again and again over the 30, 40 years, and I think is an undoubted fact. So you watch particularly those of your patients who go through menopause before the age. Now, another thing that you can do something about is osteoporosis. It's a feature that starts in midlife as estrogen levels decrease. And if you look at South Asia, which is far too near the bottom for comfort, you'll see how common osteoporosis is in the region you're all in, and that it is something that needs to be thought about, considered. I didn't know this until a few years ago. This was the case. And whoever it is on the phone, can they mute, do you think? There's somebody who's talking on the phone, but no name with them. Doctor, any chance of, thank you. That's great. Otherwise I get a bit confused.
Please mute everybody except the speaker.
Thank you. And you can see that it's in all ethnic groups. Asian women really have quite a high incidence of hip fractures. And as the age span goes up, this will get commoner because they happen in later life. What this slide doesn't show, and I must put on at some point, 20% will be dead within 1 to 2 years. 80% will have decreased mobility. Easy to assess. There's the FRAX risk assessment. There's a special page for India, and I think there is for Nepal, but I'm not 100% sure. And there certainly is for Sri Lanka. And you can use simple measures, weight, height, past history, whether you smoke, which is not so relevant for you. And if you've got bone density, so much the better. And you get a 10-year risk. You have your own that was produced by the Indian Menopause Society, giving high, medium, and low risk. Use these aids. And then you can treat women where possible. You can start with calcium and vitamin D. This is important in the Asian region to give good bone health and good advice about exercise. And then where possible, you might think of treating, and I know bisphosphonates are available in this part of the world, as are, I think denosumab is as well. HRT, great for bone density and decreasing fracture risks, but when it's stopped, this decreases very rapidly. And so unfortunately, it's not something with much of a carryover effect, which means taking it for a long time. But certainly in regard to HRT, it is very useful for symptoms. As you will all know, there are many menopausal symptoms in this part of the world. It tends to be joint, muscle pains, memory loss, emotional lability, this sort of thing. And these will be well treated by HRT. You have some regimens available, and I think there may be more coming. And it can be useful in decreasing heart disease risk and certainly in osteoporosis. So for those who are inclined, and I know the likelihood is low, it is worth thinking about and advising them of the benefits and risks accordingly. This is a much more detailed slide of the benefits and risks of hormone replacement, which comes from the publication I mentioned earlier in relation to osteoporosis. But it shows that it's mainly beneficial, with the disadvantage, of course, of increased breast cancer in those who use it on the very long term. But each person's perception of risk is different from another's. And you can see the different types of symptoms that one might expect. All of them are important, all of them are significant because they decrease quality of life, might be helped by hormones. Now I'm going to deviate a bit because it's a good opportunity to very quickly talk about cervical cancer. And 50,000 women are diagnosed with every year, and over 250,000 will die. 85% of deaths occur in low and middle income countries. This is terrifying because it could be eliminated by HPV vaccination. I'm not going to talk about that, but by screening. And so if you make sure that the women you see have had some sort of screening test, and if they've got symptoms particularly, please examine the cervix and don't just assume it's because of their hormones. And if you do that, you will help move us towards elimination of cervical cancer. In India, it's the third most common cancer, second leading cause of death, and it can, as I say, be avoided, and breast can largely as well, although I think that's much less of an issue for you. The treatment of advanced cervical cancer is really not hugely successful and is mainly palliative. We have funded 4 projects from FIGO, pilot projects, and I have to apologize to Dr. Ganesh Dongal that I haven't included the Nepal project here, which I did, and for some reason I have the wrong slide in here. And so this is the FOGSI project, which is going well. Nepal have stolen a march on India by actually getting their report of how it's going in very promptly. And so I'm looking forward to getting India's, but I gather the project is going well. And it's this sort of thing which we hope to be able to upscale in some regions in order to do more to help this. And this leads me very, very quickly into just a few words about genitourinary syndrome of menopause, the topic of this meeting. Since when you do your cervical screening in a woman around menopause, you can look for it and then ask women about the symptoms they may or may not be getting to see if you need to help. It's something people don't talk about very much. These are the sort of symptoms you get. They may be really quite severe and cause a lot of discomfort and distress. And you get signs on examination. You'll all know what they are. I don't really need to go through it again. And then you can treat it. It is incredibly straightforward for an overwhelming majority of women. You've got the simple measures, lubricants, moisturizers, local estrogen. Estrogen works well in the short term. It works well in the long term. Ospemifene can be useful, but much less data about it. And you have to take a tablet to treat something that is a very local symptom. So it's not so widely accepted in certain groups who can't take estrogen. DHEA, also very useful, less widely used because of licensing issues in Europe, certainly, but valuable nonetheless. I'm not going to talk at all about the sort of surgical innovations because others here know far more about it than I do. So think about treating. You can make people feel so much better. And you can also look at the cervix as well, which is a very, very useful thing to do. So my general conclusions are, we should be thinking about trying to eradicate cervical cancer. Heart disease can be helped, can't be eradicated, but it can be helped. Osteoporosis can be helped and prevented in some instances. And you can certainly do something about genitourinary syndrome, the menopause. So these are just simple things that might help the women that you see. And I look forward to hearing the rest of the presentations. And thank you so much for inviting me to be here.
Thank you, Dr. Marilyn Slamston. I'll invite my co-chairpersons for comments. Dr. Samina, are you there? Hello, Dr. Samina. Okay. Anyway, Dr. Mary, that was an exhaustive and to the point, in-depth analysis of the menopause. Nobody could have done it better. But before I thank you and talk about you, I have to thank Dr. Narendra Malhotra because I had to rush in a hurry. And today I was thinking that I slowed down and I went down 50 stairs and came back 50 stairs and delivered a baby also, and male baby for Indian. So anyway, so that was, and I did it in 12 minutes. I noted it. So I'm quite fit. So that is one thing. So Dr. Mary Lanston, you have beautifully highlighted one thing about the menopause transition. That is very important because that is when the most of the comorbidities are occurring. And you will be glad to know that at the level of SEFOMS now, we are doing a project of a relationship of menopause to metabolic syndrome. Because as you highlighted, cardiovascular disease is the first #1 killer in the menopause here. So that is why we had to know our own data, because so far, we don't have our own South Asian data. It's the extrapolated studies from the UK and the USA, which we are using. So wish our best for us, because we have almost half done this research survey in all the countries of the SEFOMS. Sri Lanka, they still have to start, but Bangladesh, Nepal, Pakistan and India has done a lots of data collection already is there. Secondly, what you importantly highlighted was the osteoporosis. That is another silent killer which is there, which we have to look into. And as you have highlighted, the role of exercise that is not being still utilized in the osteoporosis prevention. And secondly, I think menopause hormone therapy has been advocated now as a preventive for the osteoporotic fractures also. And many studies now have come up to prove that because it's an hypoestrogenic state, so, and the sudden loss which is occurring in the menopause transition can be looked after if we start menopause hormone therapy early in these cases. And of course, beautifully, you talked about the problems which even Dr. Narendra Malhotra will be talking later on about the urogenital syndrome of the menopause, which the women still have to bring out of the cupboard to talk about that issue, because still it is, doctor, will you please listen to me? So that is just a like sort of a private issue for the Indian women. FREX model is available, Dr. Mary, for Indian. So it is validated for India also. So we can use it. The only thing is that it is online, one thing. Secondly, DEXA machines are not that in number, and they are costly for our country. That's why we are adopting now OSTA's assessment tool for the diagnosis of FREX, I think, and for the diagnosis of osteoporosis early. Are my co-chairpersons there, and would they like to say anything? Dr. Samina, is she there?
No.
No,
Don't think
they are
so.
not there.
No.
So I think any questions from the audience? So the only thing which I will, Mary, like you to talk about is the prevention role of menopause hormone therapy in osteoporosis. Because Toby de Villiers and all others, even the Mason, they are all coming up with the studies that we should be giving it for the prevention. And I think it's safe to give, because if we are giving for hot flushes, that is an hypoestrogenic state, we know. This is an hypoestrogenic state, we know. So till the time we require for that, we can give, and later on we can then add on the bisphosphonates, Tibolon and Loxafen after 5 years giving this hormone therapy.
I'm really, really delighted to hear you're starting to gather your own data, because it's absolutely pivotal that you do. And I think that part of the issue with hormone replacement is, as you've said, that we use European data, which I suspect aren't always the same. But I agree. I think that HRT has a wonderful role in treating symptoms. It has a wonderful role in primary prevention in women with symptoms. But I think the conclusion is that there is a concern about long-term use of HRT, certainly in European and American women, because of the increase in the risk of breast cancer. Now, this numerically is small, but it's a common cancer. And risk means different things to different people. And I think all one can do, and I've always done it, is to tell people what the studies show. You know, this is the sort of risk that you might have, and these are the benefits. And then people can decide for themselves. And I think it's so pivotal that women are part of their own, you know, they're taking responsibility for their health. And then if they do develop breast cancer, they know that they were part of the decision making, and so are able to cope a lot better, I think, with it. But, you know, I'm so pleased to hear you're getting your own data and different things, because it'll be so interesting. And I look forward to seeing it.
Dr. Mary, I wanted to make one comment about breast cancer. More women die of osteoporotic hip fracture than of breast cancer. Breast cancer survival is now more than 95-96%. But the survival after hip fracture, 25% die. And the incidence is also much more. But we still have that thing, a fear of the word of cancer. That is the one thing we do. But with early diagnosis and all that, I think we can prevent everything. Let's see what the future goes, but we have to really work together. CEPHOMS and CEPHOGs. Dr. Narendra Malhotra, I think it's a really very, very appreciable that you have taken this effort of bringing CEPHOMS and CEPHOG on one platform. Because I believe women's health is a continuum. You cannot just break it down into adolescence and then reproductive health and then the menopause health. Because in reality, osteoporosis starts in adolescence. So if there is a osteopenia in that state and the peak bone mass density is not reached, those women will really more likely to end up in osteoporosis also. And osteopenic stages have more of fractures. So I think we at CEPHOMS and CEPHOG should be working together. And I invite CEPHOMS active executive members and the participants also to take all the delegates to take part in this cross-sectional study of relationship of menopause to metabolic syndrome, which is very, very important for the South Asian countries. And it's a very simple, Dr. Mary, I have kept it very simple and implementable, feasible study so that each and everyone can use. Dr. Narendra Malhotra, you were not here. I appreciated your...
No, I'm here. I was sitting on the other side. But let's invite the next speaker because the program is very
short of time. I was waiting for you.
Yes. So invite the next speakers.
So our next speaker is none other than Dr. Jaideep Malhotra. And I think she has already been introduced. And whatever words we can say about her are less, because she is not just a clinician. She is the one woman who is an entrepreneur also. And she is the one who has a thought process for the future always. The one which I can't even think of, working with the technology and developing an app and going for the higher levels and talking about the Adbhut Matritva that needs a different personality altogether. So what she is going to talk about is again new HRTs, a hope for millions of menopausal women. We depend on you, Jaideep Malhotra, and we are very eager and anxious to listen to you. Thank you. Stage is all yours for now.
Thank you. Thank you, Maninder. Thank you so much for this kind introduction. You've always been so generous. And a very good evening. Namaste, Assalamu alaikum to each and every one all across the boundaries of the world. And congratulations, Dr. Naren, for bringing all of us together on this platform. Today, I think Marian has already made my job much easier. So I'm really going to emphasize that this is one area where we already know that there are more than 150 million women who are going to live beyond menopause. So 1/3 of our life, we are going to be menopausal. And that is something which we have to all understand, because the patient pool is increasing. The aspirations are there for a better quality of life. You and I deserve to live well till we live. And that's something which is really very important. And we are in an area where no fault of us, but menopause comes in early, hits us early at a much earlier age at 46.2, which is something which is important for us to understand, because most of the times we are looking at the Western figures and the Western literature, and that's not really always applicable to us. And that's something which is really, I would ask each and every one of you to understand. Now, menopause is an endocrine transition, but it is an opportunity too. It's a great milestone. And I think this is one milestone which it's a beginning of a new life for all of us. So the only problem with all of us is that Asian women report much lesser prevalence of symptoms. And that it doesn't mean that they don't experience those symptoms. But our attitude and perception, I would say, of suffering silently hasn't changed much. And that's something which I think is one of the major turning points which needs to be there, so that we create this as an opportunity to promote and ensure that there is optimal health in this phase of life too. Now, we all do understand the consequences of estrogen deficiency. I'm not going to go into the details. This is something which you all know. But what I want to really, again, make all of you understand and emphasize here is that a patient comes to us with symptoms. Now, whenever they have symptoms, that means that estrogen deficiency is there, and there is a definite correlation of these early symptoms to what they are going to suffer later on in life. And that's something which is very important, and that is the opportunity which we should be definitely grabbing. Now, as the previous discussion was going, now we understand that 1 in 3 women will experience an osteoporotic fracture, more so in our part of the world, which Dr. Marian has highlighted. We also understand 1 in 3 will have some form of a heart disease. 1 in 5 will have stroke, and Alzheimer's and everything else is also knocking on the doors. And there's a huge, I would say, correlation between obesity. Now, this region is the obesity capital of the world. And that's something, again, very important. Now, obesity has inflammation at the back of it. Now, inflammation leads to many other coronary artery disease and many other malignancies and so on and so forth. Now, and what are we looking forward to? We are looking forward to a quality of life. Let us understand what women say. In this phase, 45% of them struggle at work. 33% feel that their social life has taken a backseat, and there can be many contributory reasons for it. We don't even want to talk about sex, and 51% feel that sex is off the menu. And that's something, again, which will hit depression and quality of life in the times to come, and not only theirs, but also of their partners. And that again can affect the families. And 81% of them have low BMD. In an Indian study, we know that about 26% of the women in the age group of under 25 were osteopenic. So what will happen to them once they are in perimenopausal age group? You can very well calculate. Now, the problem which happens is that there are so many women who understand about it. There are so many of women who are on the top political leadership, and they also will undergo all these changes, but most of them don't talk about it. They're silent. And unless and until we talk about it and we create awareness, we will not be able to have that kind of a management, which is important. Now, what is the suggested management? Very hurriedly, we have already seen in the previous talk that shifting to a healthier lifestyle. Now, this lifestyle change or a shift cannot be achieved in menopausal age group. It can be, but I think it's sometimes, too late. So if we get our children only into the habit of a healthier lifestyle, get them into, playing games, yoga, and meditation, and many other things right from the beginning, that is something which is really definitely going to help the generations to come. Maintaining a healthy diet and weight. Again, easier said than done. But yes, our Indian, I would say food in our region, it's not only India. I have been visiting Bangladesh, Pakistan, Nepal, Sri Lanka, everywhere. Our curries and our food style is full of calories. And sometimes we don't really realize. So it's very hard to stay thin in this region if you're going to eat the regular food. So we need to understand and, inculcate these healthy diet habits right from the beginning. Now, menopause hormone therapy. We never used to talk about it, in the sense that even till date, we have not risen from the problems and the issues which were raised by WHI. And I feel that it's high time. How much more time will we really, dissect that particular trial out and, understand that, yes, it has given us a lot of better insights also. And that's very, very important. So what is important here is that we must create awareness. And that is what gave birth to Club 35 Plus for the Indian Menopause Society, so that we can make people aware, we can make our own members aware that this is an area which needs preparation, not at 45, not at 50, not at 60, but much earlier. And 35 probably is that transitioning phase where if we bring about all those changes, and women are much freer with their children, grown up and husband settled, that they can devote some time to themselves. And that is where the concept was coming from. And it has come to stay. And I feel very, very happy that this club started by me as a very small club in Agra and has been adopted by the Indian Menopause Society and is the public awareness phase of Indian Menopause Society and also internationally. Now, what is important is that hormone therapy, which I'm going to talk about, has been controversial, is being debated all the time. And it's unbelievable that even today we have not been able to reach certain conclusions and reach a level of understanding amongst our own practitioners, because even when women who need it very much don't get it. And that's something which is more painful, because there is a subset of women who definitely need it, and that's important. So I'll try and make it a little more simpler and understand how do we really go about making a right choice about menopause hormone therapy, because we are so scared of hormones, the name hormones. And that's something which is really very, very important for us to understand. So what is available? What are the available hormone therapy options which are there with us? We have estrogens, we have progesterone, and we have tibolone. Now, these are the older versions which are there. I'm not going to name most of them, but now the newer versions which are available are a combination of estrogen and progesterone, and also SERMs. Now, combination of estrogen and progesterone, we have the newer kid in the block, which is 17-beta estradiol. And instead of progesterone, normal progesterone, we have dydrogesterone. And SERMs, we have bezidoxifene and ospemifene, which are not really approved and available in India. I don't know about the rest of the world. So we hardly have much choice, but we have this wonderful combination, which was there before, was taken off from the market because there were no takers. And then again, I think a lot of pressure from our Menopause Society friends, this has come back and is available to us, and which is a combination of 17-beta estradiol hemihydrate and dydrogesterone. Now, it's important for us to understand that why a certain estrogen or why a certain progesterone is the one, or what are the issues which are there with all of them that have made us so much scared and make us refrain from using or prescribing MHT even to people who do require. Now, let us first understand that we have this combination, or any combination, estrogen and progesterone. Now, progestogens are added to prevent estrogen-induced endometrial changes. Now, that is where the scare comes from. Oh, endometrial carcinoma or breast carcinoma or whatever. Now, wherever there is no uterus, you can give unopposed estrogen or as a monotherapy. But if endometrial ablation has been done, and for some reason, if a woman requires menopause hormone therapy, then progestogen addition is a good idea, and that should be looked into. Now, how do we really approach? Now, the most important thing is that if there's natural menopause, in the perimenopausal period, if somebody is having symptoms, a sequential estrogen and progesterone combination is something which would regularize the bleeding and also improve the symptoms. But in the postmenopausal period, this dose requirement is reduced, and you can lower the dose, and again, it will help us in alleviating the symptoms. Now, what should we consider when we are making a choice about hormone therapy? Let's look at the estrogens. What was available during the WHI time? Conjugated equine estrogen was what was being used. Then we had estradiol valerate, and then we are today having 17-beta estradiol hemihydrate. Now, where is the problem with all these? What we have to understand is that this did help in the symptoms, the conjugated equine estrogen, but had 2 to 3 times more extra load on the liver. And also the prothrombotic effect was there, and there was an increased risk of stroke and thromboembolic phenomena. Now, so we shifted from here to estradiol valerate. Again, the liver toxicity or the load on the liver was there. Now, what we are looking at is a minimal load to the liver, and whatever is available today is 17-beta estradiol hemihydrate, which has minimal load on the liver and is also biologically similar. So the risks, benefits, and the treatment modalities. It's really very important for us to understand what the concepts are. So as I said, estrogen alone, wherever a woman doesn't have a uterus, can be given. Estrogen progesterone for an intact uterus. We have tissue selective estrogen complexes, again, where women indication is where women have breast tenderness, or there is an increased density of the breast tissue, or there is uterine bleeding with estrogen progesterone therapy. And then you also have low dose vaginal estrogen therapy. Now, this is especially for women who have genitourinary symptoms. Again, vaginal dryness, dyspareunia, they don't really often come out with, but we must ask them. Now, looking at a progesterone, what is, or which one is the right progesterone? Now, we have number of synthetic progestogens which are available. We also have some naturally micronized progesterone which is available. So if you look here, any progesterone will have a progestogenic, estrogenic, androgenic, anti-androgenic, glucocorticoid, and anti-mineralocorticoid activity. What is available is we have progesterone, dihydrogesterone, drospirenone, cyproterone acetate, medroxyprogesterone, the major culprit behind WHI, and norethistron. Now, what we are looking at is progestogenic activity. And in many cases, we might utilize the anti-androgenic activities. We might utilize the glucocorticoid or the anti-mineralocorticoid activity. Now, these are important aspects which we have to understand, because when we are looking at synthetic progesterones, there is a definitely increased risk of cardiovascular disease, thromboembolic phenomena, stroke, and breast cancer as compared to the natural or the micronized progesterone. So if we understand well, then we are going to use them well, and that's where the benefit to the patient will be passed on. So post WHI, medroxyprogesterone acetate was a progesterone which was used during that period. And that was actually it became from hero to zero because of the various issues which were raised in that study. And that's something which is very, very important, especially the breast cancer. And that arm had to be really stopped. Now, if I go into the little depth of breast cancer, the risk of breast cancer with MHT, actually, it's not more than any general risk. But what is important is, like, if you're looking at just UK, 1,000 women, incidence between 50 to 59 years, there are 23 cases of breast cancer in UK. Now, if they are on combined hormone therapy, there are 4 more cases. But if they're only on estrogen, that means there's no progesterone, there are 4 fewer cases. So it is beneficial there. Now, just understand, if there's obesity, only obesity, there are 24 more cases. If they are consuming 2 units of alcohol per day, there are 5 more cases. If they're on combined hormonal contraceptives, there are 4 more cases. And if they're smokers, there are 3 more cases. And if they're working out at least 2.5 hours, moderate exercise every week, there's 7 fewer cases. So we cannot only blame MHT, or there are many, many other factors. So if we are looking at MHT, I would say, yes, there are many, many guidelines which are available that the risk of breast cancer is not the same with all MHTs, and the one with combination with dihydrogesterone or micronized progesterone is definitely lower. And this is how I'm just going to give you one example. There are many more examples which are there. The Finnish cohort study, which tells you that's without. These are the baseline risk, and this is with the estradiol dihydrogesterone combination, which I'm talking about. There is no significant risk. But with medroxyprogesterone acetate, with norethistron, and with other progestogens, the risk increases. Let us then now understand stroke, cardiovascular disease, and vasoembolic, thromboembolic phenomena. Now, the risk is much lower with transdermal hormone therapy containing, natural progestogens like dihydrogesterone or micronized progesterone. So that is something where you have a history or you have a high risk for these. Yes, you still can give MHT, but give it through the transdermal route. And that's something which we must understand and have clarity in our thoughts. So if you can see here, that's one study. Again, I'm just quoting here that yes, micronized progesterone and dihydrogesterone favor MHT, and they're definitely much lesser or acceptable thrombotic profile. What is the right dose? Now, as I initially only said, perimenopause and also premature ovarian insufficiency. Premature ovarian insufficiency in our country has almost about 5.5% of the population. It has premature, and I think it's much larger because as an infertility specialist, I'm seeing patients much more than what I used to see before. So these are the patients these are this group of women, I would say, not patients, who are going to suffer the long-term consequences of estrogen deficiency and are going to suffer much more. So they need to be identified and they need to be put on a sequential hormone therapy, which could be a great combination of 1 milligram of estradiol 17 beta estradiol and dydrogesterone, and continue till the natural age of menopause, or even further also. We say natural age 46, but we can continue to 50. And if they feel well, you can jolly well continue to 60 also, provided the screening is in place. Now, post-menopausal, the dose is reduced. So you could give about 1 milligram of estradiol and 5 milligram combination of dydrogesterone. Now, how does it really compare in improving the symptoms, the vasomotor symptoms? So if you see here, that's placebo, and the pink one is a lower dose, with the orange one a higher dose. So after about, if you're starting with even a lower dose, after about 3 weeks, the symptoms are definitely going to improve, and in a similar fashion with both the dosage. And that's again something which, if you don't want to really take a risk, you could start with a little lower dose, which is important. Now, what about cancer risk? Now, again, important, because, you know, we just look at this as a big taboo. And I would say here that if you're looking at no MHT, and the gray one is the risk of cancer in a normal population. Now, with MHT, you can see the blue one with normal MHT is the other, but orange one is this combination of 17 beta estradiol and dydrogesterone. The risk of ovarian, uterine, and cervical cancer is much, much lower. Now, what is the regime which should be looked into? A sequential estradiol and dydrogesterone, excellent endometrial safety, and it does regularize the bleeding pattern. And as I have already discussed the dosage, and I think it's much, much simpler. When you're looking at continuous estradiol and dydrogesterone, again, very good safety and a bleeding profile. Almost about 41% of the women become amenorrheic, and this was a study which I'm quoting. And again, there's a great safety profile. Now, a word about tibolone. Now, tibolone is a selective tissue estrogen activity regulator. So it is estrogenic, it is androgenic, and it's also progestogenic. Now, how and where does it really score over combined MHT or the combination which we are talking about? So if a woman has a significant problem as far as libido is concerned or sexual issues, then tibolone is a much better option for them. But when we are looking at the other aspects, whether it's vasomotor symptoms or osteoporosis or, you know, breast cancer risk, bleeding patterns, all of them probably will do much better with a combined MHT. So for long-term treatment, tibolone may not be a great choice, because what we have to understand is that the lipid profile in the long term, it decreases HDL and it increases LDL. And then there is weight gain, which may not be a very good option in the long term. And that's something which we should be definitely keeping in mind. Now, another very important aspect is this, because cardiovascular risk is also something which we definitely are looking into. So that's something which we should definitely keep in mind. Now, all these combinations, and when we talk about 17 beta estradiol and dydrogesterone, this is not really associated with an increased risk of cardiovascular problems. And if you see here, myocardial infarction, stroke, and venous thromboembolism, they're all much lower than even in the baseline population, which we are looking into. Sorry about this. So then comes BMD. Now, again, when you look at this, the effects on the BMD, and if you see here, this is definitely more effective than placebo in preventing the bone loss in the lumbar spine and the femoral neck. And there is a significant increase in the BMD as far as lumbar vertebra and hip are concerned. Now, let's talk about duration. How long can we take? When should we really start? So for premature ovarian insufficiency, MHT is mandatory, and you should continue till the natural age of menopause. And as I said, you can continue a little later also. Now, between 40 to 50, benefits exceed risk. So this is something which we should be definitely considering. Between 50 to 60, that is 10 years, within 10 years of menopause, again, benefits exceed risk. So this is something which, again, we have to look forward to. But more than 60, if somebody has not been on MHT, then risks have to be evaluated and then considered. And I definitely want to really emphasize that premature ovarian insufficiency is a group which should be definitely considered. So don't just write them off when they come to you. Please talk about the long-term consequences and counsel them about continuing MHT so as we prevent all these osteoporosis risk fractures and coronary heart disease, and also reduction in an overall mortality in all of them. Last but not the least is the route, because we know that oral route is much preferred by most of the women all across the world. They are almost equally effective and readily available, more affordable. But yes, wherever there is a venous thromboembolic phenomenal risk, transdermal is the choice which will definitely reduce the risk, and that's something which we should definitely be considering. So when we look at this combination which is now available to us, it does tick all the choice areas of our concern. All what we have to understand is that the balance of the benefit to the harm always needs to be assessed. And that's something which now today is making us a shift towards HRT and also menopause hormone therapy favorably, because we were so scared. But today we have a lot of these reassuring information and also combinations which are available. And I think that time is not far away where we will be able to have, this hormone therapy off the counter. And that's something which I think we are hoping for. I want to really end here with a quote from the New England Journal of Medicine, which said that by 2020, more than 50 million women will be older than 51. That's in UK. And the average age of menopause. Now, close to 3/4 of them will experience symptoms, including hot flushes, mood changes, sleep problems, and will hurt their quality of life. There are 34 symptoms that women experience in menopause, yet only 7% of the women get treatment they need. Don't you think our health systems are failing us? And that is a thought I would like to leave all of you with, because a woman looks up upon us. And I feel that we sometimes, because of our lack of knowledge or because of our passion and empathy, and even after understanding the long-term consequences, are not able to help them as much as we should be. And that is something which we should be definitely looking into. Thank you so much for your attention and this opportunity for me to address this topic.
Dr.
Very
Jaydeep.
wonderful presentation, explicitly explained and cleared all the doubts for everybody. I hope nobody will ask the questions, because you are so clear in explaining which condition, why to do, and what to do. Exactly, you did it in such a wonderful way. Really, we have to appreciate you for making this presentation so wonderfully well. Congratulations.
Yeah, and Jaydeep, congratulations for a wonderful presentation. And I agree with your last statement. Yes, health systems are failing. Absolutely agree. Because some or the other, we are not making the way forward as fast or as ahead we should be going. And for that, I think I forms countries, I again request to do their own data collection. Please, it's easy, it's practicable, and it is required. So wonderful. I think we are short.
Shall we go ahead with the second speaker?
Yeah. Yes.
We will go to the third speaker, because second speaker is having problems in joining. So we'll go straight to Dr. Preeti Jindal.
Thank you.
Yes, Dr. Maninder, please introduce the third speaker.
I can't see her slide. I have to look at her slide. But anyway, I know Preeti Jindal. And she's not only passionate about infertility, I think, which she started with, but now with the rejuvenation part of the women's health at various aspects, starting from face to lower down in the urogenital system also. And I think this is, Preeti, where you actually have your challenge, because the evidence has to be produced in this area now. But those so many studies are coming up, but how they are coming out in the favor or against will be a controversial issue for some time to come, because whenever a new thing comes up, that's always controversial, and the controversy is what makes it popular also. So that is very good, because that makes you more visibility is there because of the controversies. And if there were no controversies, I think that things won't go that easily ahead as they are going now. And of course, with the technology being our main partners, the things are not difficult then at that time. So Preeti Jindal, I think you are talking about GSM treatment by energy-based devices. So energy-based devices are lots of them, and I think the general gynecologists are normally confused about, because for them one laser is like all lasers, but there are different radio frequency lasers and ablative laser and everything. And I think, Preeti, you will be able to throw light on those different issues of the rejuvenation of the genital tract.
Thank you, ma'am. Can you hear my voice?
Yes.
Yes, loud and clear.
Okay. So as Maninder ma'am just said, GSM, we are going to discuss after a very beautiful presentation. I am a little shaken. Dr. Jaideep ma'am, you actually did such beautiful presentation, and I was taken back to my medical college years. Thank you for clearing everything. Now, genitourinary syndrome of menopause is a term coined in 2013 by the International Society for Study of Women's Sexual Health and the North American Menopausal Society. And it describes various menopausal symptoms and signs, which include somatic symptoms like vaginal dryness, burning, and irritation, sexual symptoms like lack of lubrication, discomfort, or pain during intercourse, urinary symptoms, urgency, dysuria, and recurrent urinary tract infections. And all of these together negatively affect the quality of life of postmenopausal women. So the treatment of genitourinary syndrome is basically to treat each and every one of these symptoms so that we can improve the quality of life of postmenopausal women. Now, as Elon Musk is talking of taking us to moon, we at least can use the technology to improve our genitourinary syndromes in the postmenopausal women. So this presentation will be little high-tech, and we will discuss different new energy-based devices which are available nowadays to help the women who are suffering from these symptoms. So as you can see in this chart, we have lasers with us, we have HIFM technology, then we have radio frequencies, ultrasounds, and also carboxytherapy, which actually is not energy-based device, but then it is used along with PRPs. So what is laser? We know that it is light amplification of stimulated emission of radiations, and since time immemorial, it has been used in various fields in our medical world, and in gynecological field it came quite late, and especially in the menopausal women it came in just around 15 to 18 years back, but nowadays it has been used quite a lot. So how does laser work? Laser basically, how do we decide which laser to be used? So laser is basically classified based on the media which is used to generate the laser particles. And so depending on that, it could be gas laser, it could be the liquid laser, or it could be a diode laser. Now, different lasers which are used are carbon dioxide laser, erbium YAG laser, ND YAG laser, diode laser. These are main lasers which are used in gynecological field, and they all have different wavelengths which lead to different penetration of the laser beams and the target organs. The main target organ, as you can see in this slide, is our lamina propria, where we have elastin and collagen cells, and our aim is to rejuvenate it to relieve women of their symptoms. So the basic thing which we have to understand, if a laser is short wavelength, short pulse width, and it has small spot size and low fluence, then it will penetrate less. And if it has other things like long wavelength, long pulse width, large spot size, and high fluence, it will go deeper into the tissue. So basically, the one which is very much used nowadays in gynecological practice is the CO2 laser, and that too also pixelated. So what does pixelated means? It means that the laser light is divided, the beam is divided into 9x9 matrix of 81 pixels, and so there is lasing of around 81 spots per centimeter square, as you can see this. So as a grid pattern appears, the black areas are those which has been lased, and the white areas are those which are normal tissues. So when you have normal tissues in between, it helps more easily into rejuvenation, and it is less damaging to the tissue. So when a laser beam falls on any tissue, it creates a crater, and we can see there is a central crater of ablation. Then there is little carbonization followed by coagulation, and then reversible thermal effects. So the crater of the CO2 laser is bigger as compared to the crater created by the erbium laser. So basically, how any energy-based device works. The main aim of any energy-based device is to heat the connective tissue or the targeted tissue to a temperature of 40 to 42 degrees centigrade. Now, at that temperature, what happens? The collagen, elastin, and the fibroblast cells, they are activated, and that leads to new collagenesis and new elastogenesis, and it helps in regeneration of the vagina or the target tissue. The long-term thermal and microablative effects, they help in long-term regeneration. So as we all know, vagina is basically supposed to work as a flexible tube, but due to the aging process, pregnancy, childbirth, and intercourse and recurrent infections, it becomes a rigid tube. As a result, whenever women is having intercourse, there is dyspareunia and all the other symptoms of hypoestrogenism develop. So as a result of lasing, what happens? The vaginal wall gets regenerated and it becomes more flexible. The lubrication increases, and also there is more of the feeling of the tightness, and the laxity decreases. So if we see, if the vaginal wall structure, we all know that vaginal wall is 4 millimeter in thickness, and it is composed of epithelium, lamina propria, muscularis, adventitia, and the fascia. So when the laser light fall, the photothermal heat waves, they reach just 0.5 millimeter. 4 millimeter is the thickness of vaginal wall. So many times we are scared that if we are lasing the vagina, it can lead to damage. But the penetration is only 0.5 millimeter, and the vaginal wall thickness is 4 millimeters. So you understand that unless you are doing something horribly wrong, or your machine is something horribly wrong, you cannot damage the vagina. Now, as a result of photothermal heat waves, the collagen fibers, they get shorter and thicker as a result of heat-induced collagen remodeling. And the deeper tissue layers get pulled up, and there is tightening effect and there is of the superficial layer. It also stimulates the lubricating cells, and the lubrication also returns in these women. Now, there are phases of damage and remodeling which happens whenever we put any energy-based device. So there is within first 48 to 72 hours, there is acute thermal damage phase, which leads to edema, release of chemical mediators, and collagen shrinkage. In next 30 days, there is a proliferative phase leading to fibroblast recruitment, new dermal matrix formation, and new collagen fiber formation. And the total remodeling takes around 3 to 6 months. So it's very important that when a patient comes to you with vaginal dryness, postmenopausal symptoms, dyspareunia, recurrent feeling of irritation, itching, and also stress urinary incontinence, you have to tell her that it will take time. For one laser sitting will not cure her. It is the full treatment on protocol of 3 months. One laser sitting every month, 30 days apart, and the effect will usually start coming after the second laser sitting. Because we can see from this slide, there's a proper physiology in how the remodeling takes place. So if we see the vaginal laser, we can see after doing the laser, you can see something like these pixelated white markings on the vaginal mucosa. And because of CO2 laser, it restores the pH of vaginal mucosa by liberating glycogen and acidic mucins from the epithelium that restores the pH, and as a result, recurrent infections also go away. Symptoms of dryness, itching, dysuria can be cured by increasing the glycogen that rebalances the lactobacilli and inhibits the growth and virulence of pathogenic bacteria. And also it increases the lubrication. So basically it's causing tissue remodeling, reducing the fibrosis, increasing the collagen and angioblastic fibroblastic activity. It thickens and strengthens the vaginal wall. We all know the look of the atrophic vagina in 60, 70 years old women. And believe me, even after first laser, as Dr. N.M. and Dr. Jaideep ma'am will agree, after one laser, when you call her after a month, you see that the vaginal mucosa becomes absolutely pink and young-like. So as a result, menopausal changes revert and healthy premenopausal epithelium is restored. So this is the histological picture in which you can see the retipex are restored and the vasculogenesis of the layers is also restored. We did a study at our center in 2018. I have been using vaginal laser since 2017. So it was done in 2018 till 21. And we found that for urinary incontinence, it's an amazing tool. And ICIQ score decreased at 6 months follow-up with 90% improvement in SUI symptoms. Also, if we see the G.S.M symptoms, the improvement was marked in pain, burning, itching, dryness, dyspareunia, and dysuria, and the symptoms persisted for 1 year. So the protocol which we tell is that take 3 sittings and then come after 1 year for the memory sitting. But many of the patients have not even experienced the problem even after 1 year follow-up. But we do keep on telling them that they need to come because aging cannot be stopped always. The precautions which we have to take, that there should not be any active vaginal infections. For recurrent vaginal infections, the protocol is first treat the infection and then do the laser. Always use good equipment. It should be performed by experts and it should be avoided in uncontrolled diabetes, active viral infections, pregnancy, and of course neoplasm. So as Dr. Mary Ann told in the beginning, that we should definitely take the opportunity to have a look at the cervix and do the pap smear. The advantages of these energy-based devices, first of all, there are no complications. Actually, I have done more than 300 cases now and have not experienced any complication in any patient. And I'm sure NM will also agree with it. It has been used on face for so many years. So when it is being used on such delicate area like face, and if used properly, how will it harm the vagina? And the treatment time is just 5 to 8 minutes. There is no can you mute the person who is speaking? Anyway, the treatment time is just 5 to 8 minutes. It's a coffee break procedure. You can just come from your work.
Please mute everyone. I think that is Dr. Vaj speaking. Dr. Vaj, please mute yourself.
It increases the glycogen and restores lactobacilli, restores the pH, and also inhibits the growth of virulent organisms. Other benefits are urinary incontinence, which will be discussed in the panel, and post-delivery vaginal rejuvenation is also very good with it. And dyspareunia disappears, and it also, CO2 laser can also be used as a surgical scalpel. Now, this is a picture which we all see so many times, cystocele, mild vaginal prolapse. So another thing which I'm going to discuss, the next energy-based device is the HIFIM technology, and its role is quite a lot in the removal of in restoring the pelvic floor weakness. So what is HIFIM? HIFIM is high intensity focused electromagnetic vibration, and they deliver supramaximal contractions to the pelvic muscles equivalent to 11,000 Kegel in half an hour. The patient remains fully clothed, and it's a safe non-surgical procedure. There is no downtime, and HIFIM technology is delivered through a chair. The patient has to sit on a chair, and for half an hour, we say 6 session she has to take, and it not only cures her pelvic looseness. Actually, we have seen cystocele grade 2 becoming grade 1, and also the prolapse grade 2 restoring back to the normal. And it is not a rocket science, because what it is doing, it is making your pelvic muscle strong, so it pulls it up. As we can see the hammock here, before giving the Emcella or HIFM sitting, and this is during the treatment protocol, and after the treatment, this muscles, they become strong. It can be seen even on the ultrasound. And this is a chair on which you have to sit, and it is nowadays many companies have launched chairs. So the one which I use is the BTL Emcella, but nowadays much cheaper and better chairs have also come with the HIFM technology. The next important energy-based device, which is used for vaginal tightening and for all these things, vaginal lubrication, SUI, is the radio frequency. Radio frequency is a term aimed to describe the oscillation of electromagnetic radiations, meaning to transfer energy in form of radio waves, and it ranges between 3 kilohertz to 300 gigahertz. Radiations can be either ionizing or non-ionizing. And in case of radio frequency, electromagnetic radiations which are used, it is non-ionizing radiations, and that's why they are very safe. Now, radio frequency is also delivered in form of a small spatula-like probe, which is inserted into vagina. Totally painless procedure, and the only problem with radio frequency devices is it takes a bit longer. You have to move it in and out several times, but now better machines are coming, and you have it also as a monopolar and the bipolar machines. With the bipolar machines, the one has to be very careful. There are more chances of injury, but radio frequency is also a very good device. And radio frequency, basically, what I have experienced is more for vaginal tightening and vaginal dryness. The lasers are much better for the SUI, urinary incontinence, and also for infections, and also for vaginal tightening. Then nowadays, high intensity focused ultrasound HIFU is also used for the same purpose, and transurethral HIFU is also available. It delivers high intensity focused ultrasound to the targeted area, whether vagina, urethra, or even on face it is used, and it leads to tightening. The mechanism of action is same, that is the thermal tightening it is using, but here the form of energy used is ultrasound. Then carboxytherapy is also there, which is subcutaneous injection of sterile medical grade CO2 to cause reverse Bohr effect and improve these symptoms. So basically, we have so many things available with us. What we should remember is safety profile is very important. The magic is not in the machine, it is in the magician. One should be very well trained, well educated, experts in doing the procedure. The experience definitely matters. And also they should invest in the good devices and not go for the cheap devices. They should be of standard company, and they should be well practiced ones. These are the patient feedbacks of the cases which we have done, and they are on the Google. And actually speaking, I have not experienced any complication till now with these devices. So lots of procedures we have done, we have published in ACTA. It is very important that all of you who are using this should make lots of publications, and we published this in ACTA in 2020. So thank you so much. Thank you, sir. And Jaideep ma'am, for giving me such good opportunity. And I would like you to inform that under guidance of Dr. Narendra Malhotra, sir, we have made Indian Society of Aesthetic and Reconstructive Gynecology, and I'm General Secretary of it. To become member of INSAG, you can contact me, or you can note down this email address. Another one very good book which has become Amazon bestseller is Aesthetic and Regenerative Gynecology by Sir and myself, and it has been published by Springer, so you can order it from Springer website. Thank you so much for the opportunity.
Thank you, Dr. Preeti Jindal, for that wonderful explanation and the details about different types of lasers and RF devices and everything. But first of all, I must say sorry. I could not look at your CV, so could not introduce you properly. She has come out. I just saw that later on it was a projected slide, but by that time I think I started.
It's perfectly fine, ma'am. You
Yeah.
were very, very good in introducing me. Very, I'm humbled by it.
Yeah. Two things which I wanted to be clarified was that you said it reduces infections of the vaginal epithelium. So if the patient has vaginal infection, would you be doing laser or RF therapy in those cases? Or first you would like to treat? Secondly, when it's a very atrophic vagina, would you first like to build up the vagina by some local estrogens and then try the results? I think the results will be much better in that way. So please, 2
Yes,
points.
ma'am. First question. Yes, ma'am. I did mention in my talk that first we have to treat the infection and then lase it. And how does lasing helps? Because it restores the mucosa of the vagina, and so it prevents development of needles where the organisms can sit. So as rightly said by you, we will treat the infection first and then we will use energy-based device. Now, second question is that I have done vaginal lasing in even 85 to 90 years old women, and I do not give them estrogen initially, but then definitely I give them estrogen creams application for long-term therapy, local application. But then for doing laser, we do not need to give estrogen. In fact, what I have seen that you do the laser and start the estrogen therapy for the long-term effect. It's perfectly fine.
But in these 80 years women, which type of laser do you prefer?
Ma'am, I use CO2 laser.
CO2 laser.
CO2 laser.
I
CO2
use
laser
it.
is what we prefer. That is fractionated CO2 laser is the best for in the vagina. Yes.
Right.
Even better than
I
RF.
made a
RF.
society. Now, why don't you look into this thing that these companies can bring down the cost of the laser machines?
They are doing, ma'am. Sir will tell more about it. Many companies have come. Me and sir have bought at very, very expensive rate, but now the rates are decreasing, ma'am.
Okay. Thank you very much. Any questions, please? Do we have any questions in the chat box or questions? No.
So everyone has appreciated these two talks, and it's a new technology which has to be learned. And we are now come out with papers. The Indian papers are already there. Preeti's paper is there. Mine is there. Dr. Sejal Ajmera is there. Dr. Apurva has come out with a paper. So all of us are now publishing our results. And of course, it's a new technology. When IVF came, the first two who did IVF were almost jailed. So new technology is always met with critical analysis first. So, but I think this is the future.
Yeah, it's always when the ultrasound came, nobody will get it done in the first 3 months. They said it will harm the baby. So it was very difficult to convince them to get the ultrasound done. But now the opposite is happening. We have to tell them don't need ultrasound. So they'll come for ultrasounds.
Okay, so Apurva has joined. Apurva, you can introduce the panelists. Not all panelists are there, but whoever is there, we will, a lot of them have excused themselves because of, so we will take whoever is there. Yes, Apurva or Prerna or Niharika, whoever is there.
Sir, Apurva will be taking up.
Yes, sir.
Yes, Apurva, over to you.
Yes, thank you, Prerna. Good evening, everyone. HRT is actually a very, very important topic for us. I think it's great that we are having such a international and worldwide discussion regarding this, because we've had so many patients with poor ovarian reserve that it's only natural that I think in the next 5 years we are going to be treating more patients with poor ovarian reserve and menopausal symptoms. Because it's not like 20 years ago where people are not concerned about their sexual behavior, or they're not concerned about how they are going to, physically look or feel, or even their libido, general well-being and everything else. And we have more and more women coming up to us and openly asking about how do we manage these symptoms. And it's unfortunate that not many gynecologists are equipped, or they know how to kind of deal with this. We still hear that there are people, who shun them away, saying that, this is normal, and, this is how you feel, and, you're aging, so this is how you are expected to feel. And they don't really address the medical implications that are there in this. And it's commendable that we are doing a session over this right now. And the next, what we are going to have, if we can have the, yeah, so the session, I think, is moderated by one of the, I would say, pioneers in this field, Dr. Narendra Malhotra sir. He will be talking regarding the unspoken problems of women and the entire spectrum or range of it. I don't think Dr. NM needs an introduction for anyone. There are 2 NMs in the entire country that don't require any introduction in themselves. But some of the few things that we would definitely want to highlight about sir is be the past president of Foxy, SAR, past vice president of CEFOG, director of Foxy, and and basically the king of Agra, I would say. Multiple publications and research articles, and extensively studying the problem, understanding it, and trying to find solutions for it. And the eminent panelists that we are going to have today, again, a very, very wide spectrum of doctors that we have. Professor Lubna Hassan, she's a consultant.
She's unable to join. She's unable to join. So
sure,
yeah.
Sure. So
Rubina, I think, has joined. Dr. Rubina, if you joined, say hello. I think she said yes.
Yes, Madam is a consultant gynecologist audition from Karachi. She's also a member of Pakistan Medical Commission. She's been the president of Pakistan Menopause Society. I think it's great to have a perspective. Dr. Sonia, again, another pioneer who doesn't require any introduction, director and HOD of NOAA Southern Fertility and IVF. She's the past president of Indian Fertility Society, chair of Infertility Committee, Foxy, during 2014 and 2016. And also, again, very importantly, being the past president of Indian Menopausal Society, started in a very, very, almost about 15 years ago. Our next panelist, Dr. Leela Vyas, she's a gynecologist and OB-GYN from Jaipur, has extensive interest with respect to high-risk pregnancy, endoscopy, and I would also say cosmetic gynecology. Again, one of the first few, players to kind of lead by example and enter into the management of G.S.M with respect to energy-based devices. Our next eminent panelist, Dr. Bagala, is a consultant OB-GYN from Sri Lanka. He's been the chairman, education and for standard guidelines at Sri Lanka College of Obstetrics and Gynecology, chairman for guidelines subcommittee at CEFOG, past president of Menopausal Society of Sri Lanka. I think the panel is only going to get more and more interesting because we have all the CEFOG nations and the past presidents and committee chairs that are there. Our next panelist, Professor Dr. Ganesh Tangal. He is a president of Nepal Society of OB-GYN, senior consultant at Kathmandu Model Hospital. He's received his medical degree and master's from Tribhuvan University, also been a faculty at the Kathmandu University of Medical College. So again, with respect to medical colleges, we do see a lot of patients who have menopausal symptoms. I think more than the private sector we see in the government sector. Dr. Purp Dorji, his Majesty from Medical Unit from Bhutan. He is the editor-in-chief of Bhutan Health Journal and also the professor of OB-GYN at the Medical College. Subspecialty in maternal-fetal medicine at Bhutan itself. He's also the founder chairperson for the research committee at the center. Dr. Trina from, again, Dr. Shaijush. Do we have Dr. Trina?
There, Dr. Trina from Afghanistan.
Dr. Trina from Afghanistan. We're so glad to have you here, madam. And I'm sure your expertise is going to speak for itself in the discussion that we are going to follow. And our very own Dr. Shaijush Nair is the chairperson for Midlife Management Committee. I think now midlife is wherein we know we need to kind of start having HRT also. It has literally become of that spectrum. He's also the chairperson of Research Committee at Kerala Federation of OBGYN, South Zone Coordinator for FOXY Committee of Breast Disorders Public Awareness, President of Kannur Society, and more importantly, a fertility specialist from ARMC IVF Center in Kannur. Thank you so much for joining us today, Shaijush, and excellent work regarding this. Dr. Our very own Dr. Mohammad Wahaj from Kabul. He's been a frequent guest to multiple conferences for us in India, and it almost feels like Dr. Wahaj is a part of the Indian fraternity as well. Despite his difficulty with respect to networks and everything, Dr. Wahaj is joining us today. Thank you so much for being with us here today, Dr. Wahaj.
The next two have not have said apologies, so we can skip that.
Sure. Thank you so much, sir. I think over to you.
So greetings to everyone. We have heard a lot, and we'll just try to summarize in this panel discussions on what is the experience of every one of who is handling menopause, women's health and everything. And on behalf of the International Relations Committee of CEFOG, I welcome you all to this webinar series. This is the last one of this year. Next year, we're going to start with something new. And we've had it with RCOG, FIGO, Iron Donald School, World Federation of Perinatology, with all possible federations of the world. We've had this with the CEFOG. So let's go ahead and ask everyone, how does this, let me just give you, how did this aesthetic medicine or aesthetic gynecology word came into being? There were these three dermatologists who were taking a Mediterranean cruise ship holiday, and they were discussing about aesthetics. So that's how facial aesthetics, nasal aesthetics, breast aesthetics, and they said, why not go into gynecology? And that's when they came back and made partners with some gynecologists and started with gynecologic aesthetics. So let me talk to Dr. Sonia Malik first. Madam, what do you feel are women's unspoken problems? They come to you and they don't tell you, you prod them, and then they come out with these problems. Dr. Sonia Malik.
Sonia, madam, I think you need to unmute yourself.
Myself, yeah, sorry. So thank you so much, Dr. Narendra, and thank you for making me a part of this very unusual webinar. It has been a great learning experience, or whatever has been spoken in the past lecture by Preeti has been an eye-opener, I would say. And of course, the other two talks were brilliant. So coming to what we are talking about, the unspoken problems, anything which is related to the vulva and vagina is always unspoken. Women do not like to talk about it. Anything, barring, of course, when even with prolapse or even with the organ prolapse, they will not come and tell you unless they have reached the 3rd degree stage. Whether it is a woman of the cities, whether she may be very, very upmarket, she is still very hesitant to talk about anything to do with the genital tract over there, because she feels it is indecent to talk about these things. And as far as the doctors are concerned, our own fraternity is concerned, I think we also hesitate in talking about it. And studies conducted about this have said that only 3 to 4% of doctors are actually talking and prodding about these problems with the patients. So yes, it is a large problem. People do not like to talk about all these things that you have listed over here. Things like, incontinence, even if it is fetal incontinence, they will keep on suffering, but they will not talk about it. So yes, there are lots of unspoken problems among women.
So Dr. Shaijush, you being the chairperson of the Midlife Committee, how do you think we can create awareness that women come out with this and the doctors understand this? The normal gynecologist hardly gives 2 minutes to a woman in the OPD. Yes. And these are not 2-minute problems. They have to be. So what do you feel? What are you doing about this?
So thank you so much, first of all, for making me a part of it. Such a privilege to be here amongst all the stalwarts. I think one of the basic things which a general gynec OP is missing in our country is the element of privacy. It definitely needs to one-to-one talk. You can't expect them to be standing probably amongst 10 other patients and talking to you about the appearance of their vagina or labia or about a problem with her libido. I think the first thing that we need to ensure is privacy in the premises of a gynae clinic. And I'm so happy that at least certain specialized clinics and the private setup has come up and done some good work. And they have totally altered the clinic or hospital atmosphere, and they allow a one-to-one conversation, because of which our patients are able to open up well. And I think all the good work that has probably happened with regard to women empowerment in the country as well as across the world has enabled our women to actually talk about their genitals, because it's never a taboo. They have started openly talking about a lack of a sexual excitement or libido, especially in the post years of childbirth. So I think things are on the right track these days, but at least the element of privacy, I think, is something which is lacking in most of our gynecopies.
So we need menopause clinics. We're one-to-one. We need specialized. So we need adolescent clinic. We need menopause clinic. We need fetal medicine clinic. We need AUB clinic. We need antenatal clinic. So what one poor gynecologist? Where are you going to sit? One weekday every day, or and of course an IVF clinic. So we are dividing into super specialties. We are. Dr. Trina, let me ask you, Trina from Afghanistan. What is the problem in Afghanistan? How do you get women talking about this, and what do you do? Dr. Trina.
First of all, greeting to everyone, and it's a great pleasure for me to join this valuable webinar. As a obstetrician and gynecologist in Afghanistan, I think the lack of awareness about the G.S.M or for patients and also for the doctors. And also they think the sign and symptom of genitourinary tract atrophy, dryness of vagina, dyspareunia, and much more problems very common in postmenopausal women in Afghanistan. And also these things are embarrassment to share with their doctors. Because of that, I requested from all Afghanistan gynecologists and obstetricians to focus on these symptoms and talk.
So do you get hormone replacement therapy? Do you get easily all the medicines to give to these menopause?
No, right now.
So that is again a problem. I mean, lasers and all will become after a very long time.
No laser therapy. No laser therapy.
So let us go to some cosmetic aspects. Wahaj, I'll come to you just now. Dr. Wahaj is more of a gynecologist now because he's into ART. And let's ask him also first. Dr. Wahaj, you do a lot of ART, ovum pickups and everything. At that time, do the women complain about these problems? Do they complain to you, or they've just come for pregnancy and that's it? Or a scan?
When we say the unspoken problems, really it is applied for Afghanistan. Women in Afghanistan, even their old age, menopausal age, they are very shy. They are not able to speak to their doctors. It's the one problem. The other problem is the mistake of our gynecologists. They do not advise their patients. They are not very free with their patients, and never this matter has been spoken by the doctors to the patients. So we are lacking this problem, and this is a big issue in Afghanistan. And the other thing, laser and all these things are very far, but the simple treatments, hormonal treatments, if I say even our gynecologists, they are not aware of this, I'm not will be wrong. So what we need, that our Society of Gynae-Obs should take it as a part. And even there is no committee for menopause in Afghanistan. I have never heard about this. Madam Ahuja asked me to join Menopausal Society. I said, I'll ask our Afghani doctors to come, gynecologists, but nobody come forward. So this is the problem in Afghanistan.
This
Hope our
has been the
Indian
problem in all the CEFOC countries have faced similar problems. We are even in India and the other places, the knowledge about HRT, MRT, lasers is very, very limited to a few hundreds out of the 1 lakh gynecologists which we have. So let's go to the cosmetic aspect of women. Now you see, women are not very happy with their body. And when I did a survey, this is a survey done by us, 58% women were dissatisfied with their face, 67% with their body, 48% with their nose, 37% with the genital area, which was an eye-opener. We did this last year. And overall, 69% of women wanted to look like a model, and only 29% of women were happy as they are. So, Dr. Terina, are people coming like for this? That I'm not happy with my face, not happy with my body, I'm obese, I'm too thin.
Yes, sir, we have too many patients or too many women to come to our clinic. They have problem with their face, they complain from wrinkles, they have problem from their libido problems, and also they have too many complaints. Yes, we have such patients.
Dr. Sonia, what do you think? Delhi, practicing in Delhi, how do you, I mean, as a gynecologist, do women talk to you about all this? Or they go to a dermatologist and...
No, they do come to us. They do talk about these things. I don't think we are any different from the others. Every woman wants to look beautiful in whatever way. So I suppose, yes, they do come and talk to us. But I wanted to talk about the Middle East more than this. I worked in the Middle East in the 80s.
Yeah.
And, over there, it had been a fashion even at that time that we used to, suture the hymen again after multiple pregnancies. And we also know that in Sudan, there is the labia are stitched so that there is it is a kind of I do not know what is the religious aspect of it, but the labia are stitched, and then we had to cut open the labia and deliver the baby and re-suture the labia again. So, these traditions have been going on in various countries. And the hymen has a very big importance, as tightening of the vagina was very important and very prevalent, even in the 80s. And when we had no lasers and things like this, we used to just suture them and make the vagina tight. So women have been aware of all this, and they have been wanting all this, no doubt about it. And now it is increasing.
Probably the men in the Middle East have been wanting about that.
Yes,
and
four marriages are allowed for women as well as men.
So that is why they scared. Right now also, Dr. Rupilla Bhatia from UAE is joined with us. She is putting on the Q&A, her experiences. And I've been to a couple of clinics of Ruby and everyone, and the phenomenal amount of work on vaginal tightening and sexual rejuvenation they are doing. And it's too much. So facial, body, genital, all that awareness is coming, and even in there. So the question is, do we really need a specialty called cosmetic, regenerative? So these people, is the need real? Dr. Sonia?
See, Dr. Malhotra, as Apurva was stating a couple of minutes ago, we are having more and more women with premature ovarian insufficiency, and we are having lots of estrogen deficiency in our patients. While they're trying for a pregnancy, they don't seem to be coming up with that estrogen deficiency because they are constantly taking something in order to get pregnant. So that is not evident at that time. And we also know that these vulvovaginal problems and these laxity of the vagina, etc., come as a second stage in postmenopausal women as well, not in the early. But however, if the menopause is going to set in early, if these estrogen deficiency states are coming faster, then definitely this thing is going to really be required, because women are going to live longer, and it's not an easy task to live in that state, in that dilapidated and sort
I
of
know
disfigured state.
quality of life,
Quality
QOL,
of life
quality
is
of
very,
life
very
is coming.
bad, especially with SUI prolapse and stuff like that. I
Yes,
would
they're
say,
leaking, the pads are there,
absolutely.
everything.
Yeah.
Shaijes, what do you think?
It will be required.
Midlife committee should take care of all this, or we form another committee of regenerative gynecology?
Good question, sir. I don't think Foxy can probably afford any more committees. I think they have had enough, I believe.
I think this is coming. If not next year, we already have a society. We have a world society. We have European society. We have an Indian society, which is 3 years old now. We have a dermatologist who have come out with another society, and we have 3 societies on regenerative gynae in India already. So I think
totally appreciate. Yeah, so totally appreciate the kind of work that is being done. And I think, especially as I mentioned earlier, whether a gynecologist can handle all this in his or her own setup where she manages general gynecology, obstetrics, and IVF and rest of the things, I think that will be a big question that he or she will have to ask himself or herself, because this requires dedicated time. This requires a good conversation. This requires a very detailed assessment of the problems and probably choosing the right form of treatment. So definitely it's a specialty. Whether the gynecologist can upgrade himself or herself to learn this art, that is, I think, up to them. But it's definitely the need of the day. And I think gone are those days where we used to think that the prime age of a woman is still her childbirth. And after all, after that phase, it's actually okay to have a lax vagina. It's okay not to have a sexual excitement. It's okay not to have a kind of sexual desire. I think we have gone past those days, and we are talking about rights of women, and that includes her sexual rights and her rights regarding her genital parts also. So I think the speciality is definitely the need of the day, without a doubt.
So last 10 years of OBGYN passing out MD, 10 years in our times, we went for ultrasound. Then 5 years after we went for laparoscopy, and then ART, and then fetal medicine. Nobody wants to do obstetrics. So now when they come to me, the freshers, I said, go and buy a laser machine, just sit 10 to 5, and you'll be satisfying a lot of women, and you'll be earning a lot of money also. So all this is coming, and all this is there. And can you quickly tell us why aging happens and why laxity is happening? Shaijes, you and Terina. Shaijes, yes.
Yeah, so primarily there are 2 things related to this. One, as I already mentioned, is about childbirth, the trauma that actually she has to go through, especially if she's undertaking a vaginal birth. But probably with the more number of cesareans unfortunately happening, I think that part is probably not a very significant percentage as years before. The other part is definitely regarding the hormones, because estrogen is what keeps the entire vaginal epithelium intact. The urogenital zone is kept intact, and it becomes an integral part. So when she has a deficiency of estrogen, I think she starts suffering from then on. Her sexual as well as her urogenital intactness, I think it's a downhill course from there. So primarily 2 things.
Dr.
One is
Terina,
about childbirth.
Do women in Afghanistan smoke? And Dr. Terina?
Yes.
Lifestyle.
Two less women smoke in Afghanistan.
So there are many factors of lifestyle in menopause. Genetics, of course, we cannot do anything about it except now the stem cell. The next specialty which we are going to have is regenerative stem cells, where we can rejuvenate you. So let's come to one by one quickly. Stress incontinence, a quality of life problem. And you just heard Dr. Preeti said, of course, we'll do all the general treatment. What do you feel about Kegel's exercise? Dr. Wahaj and Dr. Trina, do you tell the women to do exercise?
Yes. In daily practice, maybe I advise 2-3 patients, maybe more patients for Kegel exercise, because too many patients come with urinary problems, genitourinary problems, and I advise Kegel exercise.
Do they improve after exercise?
Yeah.
They do.
So Kegel exercise, if done correctly, with the right posture, with the right amount of time, improves.
I show them.
You can't. Yeah. You can't tell them sit on the tight and loosen. That is not Kegel. So to make things easier, there's a Kegel meter available, Kegel master available. So we have a device which you can buy from Amazon. And this gives you 5 strengths of power and gives you the exact place where the massage has to be, where the strengthening of muscles. So we Kegel exercise is one of them. So what
I want to
uh,
educate myself a little. I want to educate myself. Maybe you people would know it because you're doing all this. What is the efficacy of this in our own patients, given that our own tissues are much weaker than the tissues of, say, Afghanistan, because we are a highly vegetarian society and we don't have that kind of protein and muscle power as the Afghans and the Middle East, So I want to know from the others as well, from Nepal and places like that, what is the difference? Because when we do a cesarean in a patient who is not from India, even if she's a Nigerian or anyone, you find that you are cutting a different kind of tissue,
Yes.
No?
Yes.
So maybe that also is, here we are finding a lot of, very bad laxity amongst the women over here as compared to the other countries.
That's what I said in that slide. Causes, genetics also, genetic factor is there.
Absolutely. Yeah.
And just doing Kegel exercise will not improve. It has to be combined with all the others, hormonal therapy, estrogen therapy, interventional therapy, lasers, which we are there, surgery. Now, these are the very complicated surgeries which are done for SUI. And if they land up with a urologist, with even the mildest of stress urinary incontinence, they'll be cut. While a lot of them can be treated with simple things like lifestyle, bladder training, pessaries, vaginal mesh surgery, and of course, now we say that lasers, and this is how we do for lasers. So let's see, we have already defined genitourinary syndrome of menopause. It's a name which has been given to a combined diseases which is there. So what is even vaginal atrophy is genitourinary syndrome. So this is what we are doing for genitourinary syndrome. I don't know how many are doing this. This is the laser, with robotic laser, fractionated, which Preeti was talking to you. So it automatically measures the depth of the vagina, and you see it will rotate, and with the foot we start lasing. And after the laser here, which here Dr. Alex Bader, when he came to Agra, he's doing this case. Then we put in, because it's created micro holes, so we put in PRP in it for better healing. So these are the things which will work for what we have no treatment. We have no treatment for vaginal atrophy except for creams. One cream, then she's not happy, she goes to other doctor. So vaginal atrophy in Afghanistan, even they are finding it difficult because they don't even have estrogen. So I don't know what they are doing, what creams and all they're using. So vaginal atrophy is something which we have to look after in genitourinary syndrome. Yes, Dr. Terina, Dr. Strajas, your comments on vaginal atrophy in women. See, they come with like this. They come with this bad infections. Just treat the superficial infection.
For vaginal atrophy right now, just estrogen, local estrogen creams. Yeah, and for some patients also we recommended HRT according to their condition.
So you get HRT and local estrogen in your country?
Yeah, yeah.
Or a lot of them come to Delhi and buy in bulk and take them from there. That is also happening. So genitourinary syndrome will occur so many things. And this is what we are saying, that now we have to look at the newer devices. Now see again, vulval pain. What do you do for vulval pain, Dr. Shaijas or Dr. Wahaj? Vestibulodynia.
Very distressing.
Xylocaine injections. In my time, deep transverse incisions, what my professor told me, which was very gruesome, which very cuts bad. The nerves. So this is again, we have energy-based surface devices like this, which we are now using. What will you do to a model who comes to you that my genitalia labia are very thick and they shine when I wear my skin tight clothes because I have to walk on the ramp? and what they want is a Barbie look. If they come ask for a Barbie look, will you give it first? If you know how to do this surgery. Dr. Shaijas, Dr. Sonia?
I have
People
no
are
clue.
asking for this, so I'm shocked. I mean, I'm relearning all my obstetric gynecology now.
I have no clue. I have no clue.
So this is how we've changed
And
the
if I
looks.
have somebody, I know whom I have to send them to. Either it
madam,
is you
see,
or
this
it
is
is
how
or it is
this lady.
Preeti Jindal. Either of the
Yeah,
two are going to do it, not me.
this lady had a big. This was showing through her see-through clothes which she was wearing, and we had to do it like that, and you can do it like that. So these are the surgeries, but there's a big but and a big question mark. It comes under a thin line of genital mutilation.
Absolutely.
So you're cutting a part which is normal of the lady. So that again we have to look at, and we can offer her all the devices which we have already talked about. There are some non-gynec uses in cosmetic. So if women come asking to you, will you do it or send it to? Now women come to us. So we have to, a lot of times we have to handle the acne, the stria, the marks. And I think this is where the new speciality will come handy. So this is where this knew it. And I've got all the experts in this all over the world talk about this. These are lovely videos. It's there on the YouTube, and you can hear Caroline, you can hear Alex Barder, you can Prabhu, you can Preeti, and all of them. So let's finish this orientation panel. The need, let us say, is real. What we have to understand is first, do no harm. Counsel the patient that it is normal. And if you're not happy with the normal, then of course, as the women decide, because now it is she demands, she deserves, she gets it. Try to be as non-invasive as possible to handle what she wants at this, and recognize the unspoken problems which she has. So thank you very much, panelists, for bringing out these important things which can be there. This panel can go on for hours and hours, but that is how we briefly want to tell everyone who's attached here. So thank you very much.
Thank you very much.
Manindra,
Thank you once again. This was great learning for us. Thank you so much.
Thank you, Dr. Naren Malhotra, for bringing SEPOMs and SEPOGs together. That is one direction where we should be working together now. And thank you for bringing midlife problems to the light of SEPOG people also, who have been dealing with reproductive health only.
Now I would like to invite Professor Yusuf. Yeah. Any comments?
Panel, yes. You are 100 years ahead. Your thoughts are 100 years ahead. We are agree with you.
Madam, this is 100 years. It will be a totally artificial human being. And women will be delivering in plastic bags. Then no one will deliver from the womb.
Sir, no, sir. I mean, at that time also, why only women, sir? I think now men have to start delivering. So that is what
men will start delivering at that time. No, the deliveries will all happen in artificial wombs. No one will deliver.
Yes. There will be a revolution, there will be an evolution, and we'll go back to the same condition where we evolved from the jungles. So we'll have to go back to bring ourselves back to the normal.
Let me now invite Professor Yusuf Latif, the Secretary General of SEPOG, to give the concluding remarks and propose a vote of thanks. Dr. Yusuf from Lahore.
Sir, thank you very much. And it's indeed a pleasure to come in here and listen to everybody. And as Dr. Narendra said, that it was an kind of an eye-opening for me of all these things and these coming in. And these are kind of the videos which we kind of imagine could happen in the lifelong, and we are grateful that it has happened. Which is the things which happen in James Bond movies, now you can see that in reality. And it's exactly the same thing, which kind of how we are evolving and getting to know it. And of course, there's people who were kind of debating about there was difference in cultures and in Africa, in Middle East, maybe coming into subcontinent area, and even when doing surgeries on different part of the world, it feels different. So everybody requires to have their own. And I think as it goes on and on and on, it's never ending. And it's Dr. Narendra, I think you are not only 100, you are 110 years ahead of everybody right now. And hopefully you're dragging everybody of us, that's the good part, to be there with you and hand and learning these things. And that's in the end is a benefit to everybody. On behalf of the Saffock family and everybody, it's indeed a pleasure to see everyone. And let's hope that these kind of continue with the guidance of Dr. Rohana and pushing and Dr. Narendra, and of course upcoming President Dr. Shyam. And we are all there, and it was indeed pleasure to see each other in Sri Lanka, and hopefully we'll see that soon. On behalf of the Saffock family, I thank you everyone, and especially all those who have joined us, and hopefully we can benefit our patients. So thank you everyone, and be safe, and good to see you all.
Thank you. Good night.
Good night.
Thank you, everyone. It's been a pleasure.
We'll circulate the link to everyone of what happened, because it's all on all the previous ones also. The year end has come. Dr. Rohana, I'll come with a new proposal for next year very soon to you. And that very soon might be tomorrow.
We expect nothing less from you, sir.
So please give us a breather also. All right.
Good night. Good night, everyone.
Good night,
Good night, everyone. Thank you for joining.
Bye. Bye, everyone.